A very good evening. So I hope I'm audible and visible to all of you. So can I get a quick thumbs up if I'm audible and visible to you? Just let me listen myself. Am I audible? So I hope I'm audible and visible. Yes, I think I'm audible. So very good evening, guys. So actually, yesterday we thought that today we'll do oncology, but I thought I should give you some more time for you to prepare for oncology. So I didn't want to start and dump you with oncology in the very new sessions of which I have started for all of you. So today I have started the image based. Today we'll see all images. Today we'll mainly see all the images, okay? Right. So we'll do image-based test today. Let's start with the questions. So welcome to the platform. I am Dr. Ramyasri. Very good evening, Rehma, Vicky, Vishal. So let's start with the question. A 35-year-old woman with 3 years of infertility came to the hospital for further investigation. Vaginal smear obtained on day 22 shows the following. What is the diagnosis? Is it an ovulatory cycle? Is it an anovulatory cycle? Is it a premature ovarian failure? Is it bilateral cornwall block? Today I have very less audience of you. Your class didn't end yet in the Arise. Okay, what is the image here is showing us? What is the image in this is showing us? So what are these cells called as? And what are these cells called as? So we mainly have 3 types of vaginal epithelial cells. We mainly have 3 types of vaginal epithelial cells. That is superficial cells, intermediate cells, and basal or parabasal cells. Basal or parabasal cells. And these cells can tell us the hormonal study of the woman. So based on noticing what cells are there, we can tell the hormonal study of the woman. So for hormonal study of the woman, you should take the smear from the lateral fornix of the vagina. That is also one of the MCQ. So for hormonal study, you should take a smear from the lateral fornix of the vagina. So you mainly have 3 types of cells: superficial, intermediate, and parabasal or basal. So the image which you're seeing here, so pink color, pink and polygonal are superficial cells. Pink and polygonal are superficial cells. Pink polygonal superficial cells are under the influence of estrogen. Pink polygonal cells are under the influence of estrogen, whereas blue polygonal cells are under the influence of progesterone. Estrogen, very good Vishal, estrogen is the superficial cells. Progesterone is intermediate cells, and you also have basal and parabasal cells. You also have basal and parabasal cells. So what are the basal and parabasal cells? Basal and parabasal cells are round to oval and more of a nucleus. So this is a parabasal cells and these are basal cells. If you observe, the size of the cells is decreasing as size of the cells is decreasing and the nuclear size is increasing. The parabasal cells are round to oval. Same with basal cells. Basal cells are completely full of nucleus. Very good, excellent, Vishal. Basal and parabasal cells are predominant in menopause. So you're correct. Superficial cells are predominant in the are under the influence of estrogen, whereas intermediate cells are under the influence of progesterone. Basal and parabasal cells are under no hormonal predominance and they are predominant during pre-puberty or postmenopausal. So this image of the vaginal epithelial cells is very, very, very important for us. So now we'll go back to the question. I'm little not very, yeah. On day 22 of the menstrual cycle, what type of cells do you should see? On day 22 of the menstrual cycle, what type of cells you should see? So on day 22 of the cycle, which is the hormone which is predominant? On day 22 of the cycle, it is the progesterone which is predominant. If progesterone is predominant, which cells you should see? You should see increased intermediate cells. So you should see more of the blue color cells. But here you're seeing more of pink colored cells. So what is predominant here? On day 22 also they're having predominance of estrogen. So they are having more of the pink or superficial cells. They are having more of pink or superficial cells. Okay. If you have on day 22 more estrogen, is it an ovulatory or anovulatory cycle? Excellent, Vishal. This is an anovulatory cycle. So this smear on day 22 is showing anovulatory cycle. Just give me a minute. So this is an anovulatory cycle. So you know this is how we can interpret based on the vaginal epithelial smear whether she's having ovulatory cycles or whether she's having anovulatory cycles. So if I would have got on a day 22 more of blue cells, less of pink cells, I would have considered this as ovulatory cycles, right? So let's go to the next question. A 40-year-old woman presents with the left iliac fossa pain in pregnancy. The pain is intermittent and cramping. She has had difficulty sleeping because of the pain, but has not taken any analgesia as she is afraid that this might affect the baby. First and foremost, 40-year-old conceiving is something like, you know, it's a elderly gravida, right? So she's having some intermittent cramping pain. There is no vaginal bleeding, so that rules out abortion, right? The woman has a long history of secondary infertility. Yes, 40 years. So we can think it might be a secondary infertility. What a secondary infertility means? When a person has conceived previously and couldn't conceive again, we call it as secondary infertility. And they've started trying to conceive again soon after. She was investigated a year ago and found to have polycystic ovarian syndrome and was therefore commenced on clomiphene citrate. This was her third cycle. Her LMP has started 45 days ago. She had a positive pregnancy test 4 days back. So guys, after so much story, I think I'm lost key what is happening here actually, right? How can we put forward this question? First and foremost, she's just pregnant. She's just pregnant and she got a scan done, which is showing something like this. Okay. And UPT is positive. That's what means the just pregnant, right? So what are the positive history I have which tells us about the scan is, do you see any gestational sac in the scan? Do you see any gestational sac in the scan? This is a uterus, guys. This is a uterus because I'm having the anti-verted and anti-flexed appearance. So do you see any gestational sac here? Yes, I see two gestational sacs in this image. I see two gestational sac in this image. This is one of the gestational sac. This is another gestational sac. So I see two gestational sacs separated by a membrane, a thick membrane. So what do you think this is the diagnosis of? So another positive history which they gave us for this image was she is elderly, she is having secondary infertility, she took treatment with clomiphene citrate. She's elderly, she is having secondary infertility and she took treatment for she took treatment with clomiphene citrate. That points out towards your history, that points out your image more clearly that we are dealing with. Very good. So two sacs or it is nothing but, this is nothing but dichorionic diamniotic twins. This is nothing but dichorionic diamniotic twins, right? Did you understand how the question and the image can be interpreted? And there are plenty of the clues which they give in the question to come to your diagnosis. There is a plenty of questions which we get towards your diagnosis. Okay. Right. So let's go to the next question. A 32-year-old woman, she has no family history of congenital abnormalities. She is a non-smoker and currently drinks approximately 3 units of alcohol per week. Her only medication is 400 micrograms daily. Is it advisable to have alcohol in pregnancy? Definitely no, right? Her partner is 31-year-old and was adopted. I'm sorry. Okay, he is adopted. He has no medical problems. The routine blood booking and tests are normal. The couple opt for Down syndrome screening and the ultrasound report shows crown rump length. Okay, let's keep it aside. So nuchal translucency, NT is 3.2 mm. NT is 3.2 mm. What is the cutoff of nuchal translucency which you can have? Knuckle translucency which we can have in pregnancy. So this is a scan which you're having for the question above. So what is this image telling us? So this is the NT scan. Excellent, Vishal. So I definitely know Vishal is not NT scan is usually done between 11 to 13 plus 6 weeks when crown rump length is between 45 to 84 mm. When crown rump length is between 45 to 84 mm. And here in the NT scan, if you see in this image, you have the thickened knuckle translucency. You have thickened knuckle translucency. Can you see, very beautifully portrayed? So cutoff for NT is less than 3 mm. Cutoff for NT is less than 3 mm. If you have NT more than 3 mm, it is abnormal. And the most common cause which can have increased NT is Down syndrome. So you're correct in answering that this is a Down syndrome. You're correct in answering that this is a Down syndrome. Okay. What should be your next step if NT is showing Down syndrome? NT has shown you Down syndrome. So what should be your next step? And always remember, in the NT scan, you'll also see about the nasal bone. You also see the nasal bone. Here we have absent nasal bone. So what should be your next step when NT is showing absent nasal bone? So NT is only a screening method. NT is only a screening method. You have to go for something which is confirmatory. You have to go for something which is confirmatory. Right? So would you like to go with NIPT or chorionic villus I think how many weeks was this patient? We have to go back to see that in the question. She was 12 plus 3 weeks. She was 12 plus 3 weeks. Yes. So whenever you have a positive analyte, if they are affordable, you can definitely go for NIPT. But if you don't have the option of NIPT, then what would have been your what would have been your answer? If you didn't have NIPT, what would have been your answer? It would be chorionic villus sampling. Because chorionic villus sampling can be done between 10 to 13 weeks. 10 to 13 weeks. Amniocentesis is done between 15 to 20 weeks. Whereas chordocentesis is done between 18 to 20 weeks. Okay. So guys, I'm really surprised why today I have so less audience. Is it like you all thought it would be onco session, or you are still having the class going on in the Arise? As these sessions are mainly planned for Arise people, so I would like to know from, are there any students who are from Arise, or are they all other students whom I have in this class? No, only when you would tell me what is the main reason why we have a this. So I think we can correct it. That's the reason why I'm asking you all. Okay, I know Vishal is not Arise. I know Vishal is my student. Okay, so I get a message that you're having, okay, we have the Arise students having the class, right? So let's continue our discussion so that they can watch it afterwards also. So I hope you're all clear with the aneuploidy screening points. So aneuploidy screening points are that this are basically whenever you have a you always screen with the first trimester or second trimester markers. First trimester में which is the best screening method? Not best, which is the acceptable way of screening method, first trimester. So first trimester, the acceptable method of screening is double marker plus, that is PAP A plus NT. First trimester, it is double marker plus NT. Excellent. So that is the combined screening method. Second trimester mein, which is a preferable way of screening for the aneuploidy. Second trimester best is quadruple. Whenever you have these analytes positive, you can go for NIPT if they're affordable. If NIPT is also positive, please go for either chorionic villus sampling or amniocentesis or chordocentesis. So if NIPT is positive, you either go for chorionic villus sampling, amniocentesis or chordocentesis. Okay? So that's why your answer of NIPT was correct. Let's go to the next question. A primigravida at 39 weeks came with small gush of blood and discovered a dark red stain in her undercloths. Guys, if somebody has a bleeding at 39 weeks, what are your two differential diagnoses? What are your two differential diagnoses when you have bleeding per vaginum at 39 weeks? Mainly it means that we are dealing with antepartum hemorrhage. Mainly we are dealing with the antepartum hemorrhage. So there are two main differential diagnoses for antepartum hemorrhage. I would either think of placenta previa or I would think of abruption. I would either think of placenta previa or abruption. Dark colored blood actually already gives me one clue here. She denies actual abdominal pain, but reports there is some intermittent lower abdominal pain. So there is painful, not very much painful, but yes, some intermittent pain she's having. So painful plus dark colored blood. She's warm and well perfused. Her blood pressure is 158/87, little on a hypertensive note. The symphysiofundal height is 36 centimeters and cephal is 3/5 palpable abdomen. Matlab head has gone into the pelvis. Moderate uterine tenderness is noted. Tell me what is your diagnosis here? Is it placenta previa or abruption till here, based on till here? So guys, this was asked to you in the FMG 2020. So please remember, whenever you are having a case history like this, if you have painful bleeding, it is abruption. If you have painless bleeding, it is placenta previa. If you have painful bleeding, it is abruption. If it is a painless bleeding, it is placenta previa, right? Uterus is soft, but during palpation, two moderate uterine tightenings are noted. On speculum, cervical os is closed and there is a moderate amount of vaginal bleeding. Very good, Chendu. So as you're telling, this is a case of abruption. Why it is a case of abruption? Because she's having pain also and she's having uterine tenderness. So painful bleeding is abruption. Oh, they have given us a CTG. So, and they're asking us what is the management. So summary of the question is, I'll put the summary of the question so that you can read the CTG and answer accordingly. Okay. So it is a 39 weeks patient with abruption, with, how is the CTG? You should tell, with or without fetal distress. So who will tell me how is the CTG? Yes, Chandu, Vicky. So always remember, first and foremost, there are uterine contractions. So this is a CTG, okay? And this is the baseline. This is the baseline. So baseline is where you see the maximum baby's heartbeat. So here the baseline is showing 120 beats per minute, right? And baby ka heartbeat is never on the same line. Baby's heartbeat goes up and down, up and down. So depending on how many boxes, if it is going up and down, you call it as beat to beat variability. So beat to beat variability is going in 2 boxes almost. So beat to beat variability in this is 10 beats per minute. It's good. Do you see any diesels or do you see any axles here? I want you people to answer for axial or diesel at least. Axial means from the baseline, whether heart rate is going up, or from the baseline, the heart rate is going down. From this image, what do you feel? The heart rate is going up or the heart rate is going down? Do you have axles or diesels? We have only axles here. We don't see any diesels. Do you see any down of the baby's heartbeat? No. Everywhere I'm seeing them going up nicely, beautiful up. So although there is abruption, baby's heart rate, baby is still fine. So it is without fetal distress. It is abruption at 39 weeks without fetal distress. So what should be your management? Again. So I'm telling you this again and again, because this is the same concept question which you got in your FMGE 2020. The concept of the question is same, only the framing is different. I tried to put little more masala in the question, so that you reach to that question. So I'll quickly speak about abruption here. See, premature separation of placenta is called as abruption. Premature separation of placenta is called as abruption. When placenta gets separated, uterus thinks it is a third stage. So it undergoes continuous contractions. And what does it do? It tries to expel all the products outside. And when there is a placenta separation, the blood flow to the fetus is compromised. And when there is continuous contraction, again, there is a blood flow to the fetus compromised. So as she's having continuous contraction, she'll have pain. As the placenta is getting separated, she'll have bleeding. So they will have painful bleeding. So first and foremost, in abruption, you'll have painful bleeding, which is dark or altered. As there is continuous uterine contraction, the blood flow to the fetus is compromised. So there is fetal distress too, fetal distress. And when you examine, on examination, uterus will be tender, and hypertonous. Uterus will be tender and hypertonous. You also have a classification for grading for abruption. So page grading for abruption is grade 1, uterine tenderness. Grade 2, fetal distress. 2, fetal death. Grade 3 is maternal compromise. So grade 3 is maternal distress, DIC, shock, and death also. Now in our question, which grade was she? Was she grade 1 or grade 2 or grade 3? There was uterine tenderness, but there was no fetal distress. So in our question, she was only grade 1. How do we manage? So how do we manage a case of abruption will be the next thing which we have to see. Management is you have to follow something called as Pritchard rule. See, uterus is in a josh to push out everything, and it is placenta is getting separated. I cannot tell, no, I want to wait on it. Placenta will separate and there will be fetal distress ultimately. So you should be quick in delivering, and whatever might be the gestational age, I will manage it outside. So Pritchard rule may you do immediate delivery. No, actually they're still having the class going on. I just got a message that students of Arise are still having their class going on in another class going on. So there's a clash of YouTube and class. Anyway, so Pritchard rule is immediate delivery. You should maintain the hematocrit more than 10% and urine output, more than 30%, I'm sorry. And urine output should be more than 30 ml per hour. Okay, excellent. You people are answered grade 1. I'm very happy. So, and this management protocol is very important because that was asked for you in FMGE 2020. Treatment depends on anyway you have to deliver, that we have decided. Mode of delivery, you have to check the fetal status. If fetus is dead, it means you have landed in grade 2. Check the maternal status. If mother is having DIC, correct the DIC. And what should be the mode of delivery post correcting DIC? Do you want to do vaginal delivery or do you want to do cesarean section? Uterus is in Josh to push everything outside. Will you tell uterus, by chup, I want to take you for cesarean, and let it deliver? So you will let it deliver, right? So when there is DIC, you have to correct DIC and let them go for a vaginal delivery. Next, if fetus is alive and no fetal distress, then you have to go for vaginal delivery. You should encourage a contracting uterus, right? If there is fetal distress, then take them for cesarean section. If there is a fetal distress, then you have to take them for cesarean section. Now let's go back to the question, and I want all of you to give me the correct answer. Yes. So there is no fetal distress. So what should be your management? LSCS, induction of labor, wait and watch, steroids. Is there any point of doing cesarean section here? Absolutely no. So what is the preferable thing which you can do now here? Go for vaginal delivery, that is excellent induction of labor. Answer here is B, induction of labor. Okay. So I hope we are clear with this. Let's not do one more CTG. Let's do this. The following instrument is used in, what is this instrument? And where do you very commonly use this instrument? So this is called as Doyne's retractor. This is called as Doyne's retractor. Doyne's retractor is used mainly for cesarean section. So it is used to retract the bladder during cesarean section. So this is a Doyne's retractor which you use for retracting the bladder during cesarean section. Okay. What does the following image show? Image say for you all? What is the diagnosis based on this image? Excellent. This is the intrauterine death. And what you're seeing there is the overlapping of the skull bones, which is called as Spalding sign. Very good. So this is a picture of intrauterine death. Intrauterine death. What are the other signs of intrauterine death? The first sign of intrauterine death is gas in large vessels, which is seen as early as 12 hours post death of the fetus, which is seen 12 hours post death. And what is this sign called as when you see gas in the large vessels like aorta? It is called as Robert's sign. Robert's sign. So gas in the large vessels is called as Robert's sign. Next, you have the Spalding sign. Next, we have the Spalding sign. And later we see one more sign called as Ball's sign. What is Ball's sign? Hyperflexion of spine is called as Ball's sign. So we have Robert's sign, Spalding sign, and Ball's sign for the intrauterine death. Okay, let's see the next question. What is the diagnosis of the following HSG? Yeah, sorry, hyperextension of the spine. That's the Ball sign. Very good, Vishal. What is the diagnosis of this HSG? So this is an image of HSG. Cervix is normal. Uterus is also normal. It is showing pear shape. And then I have fallopian tubes. Is there normal spillage of the drug in the fallopian tubes? Is there spillage of the dye in the fallopian tube? No, you don't see the spillage of the dye in the fallopian tube. Actually, if you observe here, the dye is coming only till here and then it stopped. It's like a cute girl with two chotis. No? So where is the site of block? Where is the site of block? You all know the parts of the fallopian tube, no? We have the intramural, isthmus, ampulla, and fimbria. Intramural, isthmus, ampulla, and fimbrial. Right? So, if you see this very, very closely, dye is going to the intramural and dye is going till isthmus also. Beyond isthmus, you don't see any dye. Dye is going till intramural and isthmus. Beyond isthmus, you're not seeing the dye. So it is bilateral isthmic block. Where do we see this bilateral isthmic block? Let's see with the options. Tuberculosis. Tuberculosis mainly can cause bilateral cornual block. Gonococci, bilateral fimbrial block. This is not cornu. Cornual block means here only it should stop. Dye should not go beyond. Post-tubectomy. Post-tubectomy. What is the site of tubectomy? The site of tubectomy is isthmus. Site of tubectomy is isthmus. So post-tubectomy, you will have the dye going till there and then stopping. So guys, if you observe the questions, these are all framed by me, where I'm trying to just, play with your concepts. Here I try to extract 2-3 points from all of you. Key, what is the site of tubectomy? That itself is one MCQ. Site of tubectomy is isthmus. Do you know why do we cut at isthmus in tubectomy? Because isthmic reanastomosis is best for reversal. Okay, so that is the second point you have learned. And third, you learned how to read a HSG also. Fourth, we learned where will be the block with pertaining to gonococci and tuberculosis. So each question teaches us a lot, and that's how I tried to frame them. Okay. So I hope you all understood this question. It is a post-tubectomy bilateral isthmic block. What is the diagnosis again based on this HSG? I want you people to attempt something so that then I can speak based on that. Thank you, Vishal. Right, what can you tell the diagnosis for this? Excellent. I wanted you people to answer unicornuate. See, when after you answer unicornuate, then I answer or explain you, then we will have more fun, right? So, this is not unicornuate uterus. I'll explain you why. If you observe closely, do you see any spillage of dye? I don't see the spillage of dye. Both sides cornua is blocked. Both sides cornua is blocked. Actually, if it is unicornuate, I should see only one side horn. In FMGE 2020, you got a HSG image as a image-based question, okay? So this is, you should have only one horn if it is unicornuate uterus. But if you closely observe the image, you actually have two horns. But beyond the horn, you're not having the dye going out. So dye is not going beyond the horn. So it is bilateral cornual block, which is looking like unicornuate uterus. So this is called as pseudo unicornuate uterus. This is actually one of my favorite question. This is called as pseudo unicornuate uterus. Okay, you see two horns. See closely, you will definitely appreciate them. If you have, see, you have an angle also here. If it is a unicornuate uterus, true unicornuate uterus, you will see banana shaped and you will see a single fallopian tube. This is a bilateral cornual block which is looking like a pseudo unicornuate uterus. Do you know what is a condition which leads to a pseudo unicornuate uterus? It is the tuberculosis. Excellent, Chandu. The answer here is tuberculosis. The answer here is tuberculosis. Okay. Identify the image. Again, identify the image.